Bose. Thank you so much for joining us.
Thank you for those kind words and that introduction, John. It's been great to work with you as well, and I'm excited to be back in Ottawa and share some of our work that we've done so far, as well as some of the future goals that we have in one area of multiple sclerosis, at least, that has been difficult to treat, difficult to measure, and not too uncommon, especially with the population as it's changing over time, and that's progressive MS. So let me just maximize my screen here. Okay, so over this talk, which is a little bit of a whirlwind, I'm hoping to be able to show you all the advances in how MS pathophysiology and treatment has improved over time, but also highlight the gaps that remain in progressive multiple sclerosis. And I'm going to spend some specific time on looking at different outcome measures, early detection, as well as novel treatment targets, and ongoing trials and future directions in this field. So to start us off, I'm going to take us back to 1983, where we're working at a hospital, and essentially a 34-year-old woman comes to the emergency room with difficulty walking. She had delivered a baby girl, healthy 2 months before. It was an uncomplicated pregnancy and delivery, but for the last 2 days, she had noticed that she was having more imbalance and this sense of the world kind of jumping around her. This video is not her, but essentially it shows one finding that's pretty classic for the particular disease that she might have. As you can see in the video, the name of the condition is right there, but either way, there's an abducting nystagmus on either eye, as well as slowed adduction of the contralateral eye, which is pretty indicative of a person who has an intranuclear ophthalmoplegia, bilateral. Otherwise, on exam for her, she had diffuse hyperreflexia, ataxia. Her vital signs were normal. There was no headache or systemic features or other concerning findings. And on spinal fluid analysis, unmatched bands of IgG in the CSF were seen that were not present in the serum. So the leading diagnosis was that an immune-mediated attack on the CNS was happening for her. Luckily, the Hospital Research Institute that you're working on was studying the use of MRI, and a recent publication of the time had shown that in neuroinflammatory conditions, MRI can be useful at finding certain lesions that are present. And so the patient agreed to be enrolled in a study to undergo this new imaging modality. And we can see from this grainy image that there are at least 2 posterior periventricular lesions, as well as at least 6 other periventricular lesions, which supports the potential diagnosis of multiple sclerosis. Now, an established treatment for these neuroinflammatory conditions was to provide pituitary hormones, which can stimulate the adrenal glands to produce cortisol and reduce systemic inflammation. So this was provided intravenous ACTH, but unfortunately there's no established treatments in the early 80s to prevent future exacerbations, which is a well-established feature of multiple sclerosis. However, a hypothesis was that viral reactivation or infection was causing these inflammatory attacks in people, and there was a trial being tested looking at a new modality to prevent viral reactivation, which was interferons, in order to help to prevent exacerbating, remitting multiple sclerosis. Now, the patient had just gotten out of their MRI scan. They were still dizzy from their INO, so they wanted to think about that procedure, that trial before signing on. If we fast forward, though, 40 years from then to 2023, we can see that the landscape of multiple sclerosis treatment has absolutely dramatically changed. There's now over 25 approved treatments for multiple sclerosis, and one major element is the advent of that MRI scan was allowing us to see and detect inflammatory activities in a much more sensitive and early way. Thus, treatments are going to be able to show a greater efficacy in stopping new lesion formation and through novel mechanisms, and in many cases, more tolerable side effect profiles, treatments have been continually advancing. In the 90s and early 2000s, there was mostly injectable treatments, which gave promise to patients with multiple sclerosis as they had a previously untreatable condition. And then during this last decade, there was an absolute explosion in oral options and high treatments that allowed patients to realistically hope to attain NEDA, or no evidence of disease activity, which means no new attacks, no new lesions on their MRI scan, and so forth. And though this decade, the 2020s, have only just started, already the pharmaceutical horizon is blossoming with many new agents in attempts to stop MS through newer mechanisms still, some of which we're going to discuss later today. But let's return to the past for a moment, now into 1984. So we see our patient at a 1-year follow-up. She had her initial treatment with that ACTH, and she actually had no further attacks. However, she never really improved in terms of her balance. And over the course of that year, she actually worsened to now requiring to use a cane to walk further than 120 meters. And a concern was that the patient was having a progressive form of multiple sclerosis. A recent article in Neurology had proposed a scale to rate disability status, the EDSS. This is a numeric scale which essentially accounts for 7 neurological functional systems: vision, brainstem, motor, sensory, cerebellar, bowel bladder, cognition, as well as ambulation, to give a patient a rating from 0 to 10. And what we see from the scale depicted down below, our patient now would meet an EDSS of 6 because she requires that the gait aid to walk. This can be a useful way to monitor patients in terms of how they're doing over time, as well as in clinical trials, and potentially show improvement or stability in a patient's neurological status. But trials aside, treatment of the patient is paramount. And there was, again, going to the 80s, a recent publication of that time in the New England Journal of Medicine that showed that this concept of progressive MS, which had been well established, has now luckily had some treatments tried for them as well. In this publication, they showed that high-dose cyclophosphamide plus ACTH was more effective than ACTH alone at halting disease progression at both the 6 and 12-month mark. So there is some hope that patients with progressive MS may also have treatment. But if we again fast forward now, 40 years in the future, the landscape has changed not so differently. Studies that had been tried in progressive MS have not been as successful. The interferon treatments were tested in progressive MS, and unfortunately, they failed to show improvement in disability scores. Glitarimer acetate is another frequently used medication in relapsing MS, but it had no effect in progression. Some higher efficacy treatments for progressive MS, natalizumab, fingolimod, rituximab, all were tried in progressive MS, and they all failed. Novel agents that had different mechanisms to try to target progression at a different level, T-Celna, which is a T-cell inhibiting medication, it too failed. Medications like IVIG, diracoatide, lamotrigine, dronabinol, all of these medications failed as well. Phase 2 studies of neuroprotective agents, biotin and simvastatin, were successful in phase 2 studies, but then in phase 3, they both also failed to show a difference in progressive MS. Cladribine is a purine analog, which had shown promise in relapsing MS and potentially some effect in progressive MS. However, in the official trial, it too failed to show a change in EDSS outcomes. And cyclophosphamide, the success story of the 1980s, was tested more rigorously in recent years, and it too unfortunately showed was a failure to basically show a difference in disability in patients with progressive MS. Now, not all is bad, but I'll leave it up to you to think about the clinical significance of 3 medications that were successful in treating progressive MS. The first was the MIMS trial, which looked at mitoxantrone, which is a type 2 topoisomerase inhibitor. Thus, it is a DNA reactive agent that intercalates in DNA, causing crosslinks and strand breaks. And basically what they looked at was 188 patients who had a treatment with either mitoxantrone or placebo. And what they found is after 2 years, the placebo group had a 0.5 worsening median change in their EDSS, with the interquartile ranges shown, versus the mitoxantrone patients that had a 0 median change with the interquartile ranges here. So modest effect at best in a 2-year period. And unfortunately for this medication, rates of cardiac toxicity, neutropenia, and liver toxicity were relatively high, and this limited the use of this treatment for patients with progressive MS. More recently, there were 2 medications that were tried in progression. One was the siponimod EXPAND trial, and this is a huge study that looked at 1,600 patients, and the main outcome that they assessed was confirmed EDSS worsening at the 3-month mark. And what they found was about 32% of patients in the placebo group had worsening versus 26%. So this meant statistical significance. The absolute difference was about 6% of people. So 1 in 4 patients got worse who were on siponimod versus 1 in 3 in the placebo group. Another study was the well-touted ocrelizumab study, Oratorio, which again looked at confirmed EDSS worsening at the 3-month mark as the primary outcome. This is a B-cell depleting therapy that's given intravenously, and what they found was 40% of patients who were on placebo had this confirmed worsening at the 3-month mark versus 33% for ocrelizumab. So a bit higher rates of EDSS worsening in this cohort. The patient population is not exactly the same, but the effect of this treatment versus placebo, again, modest at best. So compared to relapsing MS, why have treatments in progression have they been so poor? Well, there's a couple different possible reasons why this might be. Maybe we're not measuring the right thing. Perhaps in these patients, EDSS worsening isn't the best way to track them. Or perhaps we're not targeting the right pathophysiology. Many of these treatments have been developed and shown promise in their effect at stopping relapses and stopping gadolinium-enhancing lesions on MRI scans, but perhaps progressive MS needs to have a different target. And finally, perhaps we're not treating early enough. The familiar homage that once neurodegeneration and progression starts, maybe the cat's out the bag and the patient's not being treated early enough, and they've already started this progressive cascade that's hard to stop once it begins. But certainly the reason that these progressive MS treatments have failed isn't because we're not trying. There's many new medications being tested continuously, and just looking at a PubMed graph of publications, we can see that from the 1980s to present day, there's been an exponential increase in articles published on progressive MS. In the 90s, there was only 100 articles per year about. In the 2010 decade, there was about 1,000 publications per year. And in the last few years, there was 3,000 publications every year on progressive MS. So certainly there's lots of interest and focus on this topic. Now, what I want to highlight is a couple of different pathophysiologic concepts in MS in general. And firstly is that there's these clinical definitions which tries to group people with MS into these different categories. There's radiologically isolated syndrome where only MRI changes are seen, relapsing MS, progressive MS with or without inflammatory activity. And basically the point is that the treatments that we have been designed, tested, and approved based on people with MS falling into one of these buckets. And success of these trials are claimed based on the disease activity, which we can actually measure from these different buckets. Now, this type of schematic is shown pretty frequently in MS talks, and basically it's a schematic of the classical course of MS, where at some point a patient will have their first clinical attack, and it could give them transient neurological symptoms that are measured by an EDSS rise, and then they may recover. And then a person may enter a inflammatory predominant relapsing phase where multiple relapses occur. They're with or without complete recovery. until eventually a patient enters this progressive, maybe neurodegenerative phase with or without relapses, where a patient has a worsening disability. So as you can see, a patient may, start off with one phenotype and then within that same person experience a whole range of multiple sclerosis phenotypes. And on two sides of the chart, I'll just point out the less spoken about concepts of MS, one being the idea of this burnt out MS, where maybe the traditional measures of disability don't change, the EDSS stays at a certain level, but other important elements of a person's life might change, their quality of life, fatigue scores, brain atrophy. And on the other side of the spectrum, we have this concept of prodromal MS, or radiologically isolated syndrome, where a person might have gadolinium-enhancing or T2 lesions, but no clinical attack has occurred yet. However, in these patients, there's evidence showing that there's higher rates of hospitalization or doctor visits, fatigue, mood symptoms, autonomic dysfunction such as constipation that seem to predate the first clinical attack in some cases. And perhaps treatments of MS should be different based on what or outcomes of the treatments should be different based on what phase the person may be in. In terms of inflammatory activity, that's pretty well established. The first outcome that we can measure are clinical attacks. This is where patients have new neurological signs or symptoms, and these are often accompanied by contrast-enhancing lesions on the MRI, which then result in a T2 hyperintense scar or sclerosis after the fact. Original autopsy studies and biopsies show that CD8 positive T cells are identified within these MS lesions, hence the concept of this being an inflammatory attack. However, unlike some other conditions, there's no clear peripheral antibody or cytokine identified for multiple sclerosis. There's no ESR for multiple sclerosis, for example. On the other hand, intrathecally in the CSF, there is synthesis of oligoclonal IgG bands in 85% of patients with multiple sclerosis. And though these IgG bands don't target a specific antigen, this feature is something that's been well described in multiple sclerosis and several other conditions. Another interesting characteristic of multiple sclerosis is that within these T2 hyperintense lesions, there's a central venule that courses through them. And interestingly, other inflammatory conditions and other conditions that have T2 hyperintense lesions on MRI don't seem to have this feature. This central vein sign is shown here in these pictures, where basically patients with relapsing MS or progressive MS will have this vein running through the lesions that we see, while as other conditions that lead to T2 hyperintensities like ischemia or migraine have different pictures where essentially a vein is not seen running through the T2 hyperintense lesion. And even in neuroinflammatory conditions like lupus, Sjogren's, Behçet's, vasculitis, the percentage of lesions that show the central vein sign is certainly much higher and quite differentiates multiple sclerosis from these other conditions. Now, the cause of inflammation is something that is important, but is eluding us to some degree. Firstly, it doesn't seem like there's a very clear genetic predisposition in all patients with multiple sclerosis. However, there is an HLA haplotype that has been described in 60% of Caucasian people with multiple sclerosis, compared to 25% of Caucasian people without multiple sclerosis. So there may be some degree of predisposition there. And there's this perplexing sex distribution, which varies with age. In pediatric MS cases, the ratio of male to female is close to 1-to-1. In general, multiple sclerosis is very rare to occur before the age of 12 anyways. And then in midlife, the sex distribution skews significantly towards a female predominant disease with a 2.5-to-1 about ratio. And then past the age of 60, the rates of MS go back to almost 1-to-1 ratio, which makes you wonder if there's some sort of hormonal component to developing multiple sclerosis. Also interesting is this geographic distribution, which is not uniform across the world. In countries like Canada, USA, Sweden, the rates of multiple sclerosis are over 250
per 100,000 people, whilst other countries, Mexico, India, Sub-Saharan Africa, there's other countries like this, the rate of multiple sclerosis is much lower, closer to 10 per 100,000. And what's the reason for that? Vitamin D, hygiene hypothesis, genetics, gut microbiome, many different hypotheses are there. One potentially interesting inciting factor may be that people with is that lately more recently an inciting event had been identified. And this is based on the Harvard US Army study, where they looked at 10 million people who were on active duty. From this very large cohort, they identified 955 who were diagnosed with MS. And what they were able to do was match 801 of them 2-to-1 with people who did not have multiple sclerosis. And from these individuals, they captured 3 blood samples, all obtained before the onset of multiple sclerosis. And they sent it off for viral testing. And what they found was that only one person who'd had multiple sclerosis was EBV negative. This led to an extremely large hazard ratio, 26.5, which is essentially unheard of in medicine, pretty much making it convincingly obligatory for people to have EBV in order to develop multiple sclerosis. Now, one fact is that EBV is very common. In fact, in this cohort alone, there was 94% of the sample that was EBV positive. So what they found was at baseline of all the people, 35 who ended up having MS were EBV negative, and 107 of the controls were EBV negative. And over the course of their follow-up, those 3 blood samples, all but one person who was EBV negative became infected with EBV. So 97% of the MS group seroconverted. And they all seroconverted before the onset of their MS symptoms, as compared to 57% of the non-MS group who seroconverted. So this again correlated to an extremely high hazard ratio, making it pretty compelling that EBV infection predates multiple sclerosis, and potentially there's a pathogenic link there. Also interesting is, as we mentioned, there's a global distribution of multiple sclerosis, which is not uniformed. About 3 million people in the world, we think, have multiple sclerosis, and the prevalence certainly varies by region. As I mentioned, Canada, USA, Northern Europe have higher rates compared to countries such as China and India, for example. And we mentioned that a very high proportion of the world becomes EBV infected. About 95% of the population of the world will become EBV infected, but the age at exposure also varies. In this table, we can see the countries with a higher prevalence of multiple sclerosis. Around the teenage years, the rates of EBV positive people is around 50 to 70%, as compared to certain countries with a much lower rate of multiple sclerosis. The rates of people who are EBV positive is much, much younger, more like in the childhood years do they become exposed to EBV. So perhaps there's a role of immune tolerance earlier in life where EBV can be infected. It can infect the body, and the autoreactive cascade may be less important. So we went through a bit about relapsing MS and some new information on a potentially inciting factor, but now let's delve into progression. So firstly, I just want to state, what is progression itself? Well, the definition is that it's a clinical phenomenon where a person has worsening of disability in lieu of inflammatory relapses, which means it's a retrospective designation made by the physician. When you see a patient and you look back at a previous year, if a person's worsened in some way without relapses, they may meet this definition of progressive MS. Now, we mentioned the EDSS before, which is this composite of 7 functional systems, where essentially people, it's a very powerful tool. It ranges from no deficits to walking impairment to essentially self-care dysfunction or death. And it's so powerful, in fact, that machine learning algorithms were able to predict, just based on age and the EDSS, whether a person would be defined as having progressive MS by their clinician or not. It's actually quite remarkable how close the decision tree which in blue is to the clinical evaluation. So the EDSS certainly is a powerful tool at defining people as progressive or not. However, beyond simply labeling somebody as progressive or not, there are different scales to track how a person is progressing over time. And this includes functional skills such as the timed 25-foot walk, a 9-hole peg test, which looks at upper limb function, the symbol digits modalities test, which looks at working memory. There's quality of life questionnaires, fatigue and mood questionnaires as well, and cognitive testing, which certainly is an important test which we don't spend enough time evaluating in our patients. But it can certainly be something that progresses over time in multiple sclerosis. And in terms of the cause for progression, there's several different theories, and this is what we want to delve into a bit further in this talk. So the first theory is this concept of neurodegeneration, where basically as the central nervous system ages in an accelerated manner for multiple sclerosis, disability worsens and function and cognition decline. And this can be measured in some degree by the MRI using different volumetric analyses to look at brain parenchymal fraction. And we can see that over time, people who don't have MS, relapsing MS early and late, until they get to progressive MS, the fraction of brain parenchyma in the skull decreases significantly over time. This idea of atrophy is also present in cortical or deep gray matter specifically, spinal cord diameter. And in fact, some studies are looking at brain atrophy as an outcome to show an effect at stopping disease activity. The left graph is looking at the ofatumumab or Kesimpta study against placebo, which was a B-cell depleting therapy. And essentially what they showed is that over a 2-year period, compared to placebo, where the brain volume percent change continues to decrease, it decreases at a slower rate in people who are treated on ofatumumab. And everyone's brain atrophies to some degree, but people with multiple sclerosis have that accelerated atrophy. This is important because studies right now are and medications are being approved based on studies showing a clinical effect. But studies are short. They're 2 years, maybe 3 years in duration. And outcomes in MS and people living with MS go much beyond that. So if high efficacy treatments can show that brain volume is also being affected, then other novel agents can be tested, potentially with brain atrophy or brain MRI as the outcome of interest. This graph on the right is a phase 2 study that was looking at alpha-lipoic acid, which is an essential fatty acid's presence in synapses and in the brain, versus placebo. And what they found was that compared to placebo, again at the 2-year mark, alpha-lipoic acid treated patients had much lower rates of brain atrophy. And so this can be promising since these types of molecules maybe don't have intense anti-inflammatory effects to stop relapses, but may get at a different pathophysiology that's present in progressive MS. Now, why would brain atrophy happen? So this gets into a second theory, which is on CNS compartmentalized inflammation. So let's go through this study, or this slide rather, and see how that makes some sense. So on the left, we have the potential inciting factors for starting multiple sclerosis. Could be EBV infection, which this virus infects B cells, and that's the reservoir for Epstein-Barr virus in humans, and potentially it invokes this autoreactive pathology in these lymphocytes. There may be other factors such as the gut microbiome, which I won't talk about too much in this study, or in this talk. But essentially, the idea is that in the lymph nodes, these autoreactive B and T cells interact with each other. And then as these lymphocytes course through the bloodstream, eventually they get to the blood vessels in the brain that they extravasate into the central nervous system. And the first cells that these lymphocytes encounter are the neurons and glial cells, more specifically the myelin of the neurons, which are formed by oligodendrocytes. And if these autoreactive lymphocytes start to see the proteins and other features of the myelin, and inflammatory cytokines are released, which then invokes microglia and astrocytes to recruit more inflammatory cells from the periphery into the central nervous system. These are the CD8 positive cells and macrophages, and essentially these inflammatory cells lead to destruction and damage of myelin and of neurons, which in turn causes mitochondrial dysfunction, iron accumulation, glutamate toxicity, and essentially activates astrocytes to form a scar. And then all of these CNS-specific antigens start to be released and uptake by microglia, which are essentially the immune cells of the CNS. And now we have autoreactive microglia, an activated microglia within the brain itself. And this pathogenic cell can now spread to other areas of the brain that are not so close to the lesion, which is right beside the vein where the initial cells extravasated, and cause problems in other parts of the central nervous system, such as the gray matter. And this could be an important feature of how multiple sclerosis changes from a peripheral attack on the central nervous system to a CNS-specific inflammation. Now, astrocytes I'll mention in a bit more detail because they're important. They're firstly a very abundant glial cell. They make up 30 to 40% of the CNS cells, and they form an integral part of the blood-brain barrier. And they have kind of two main phases. One is under physiologic conditions where astrocytes are involved in ion balance, water transport, and so forth. But then when there's a reactive attack on the brain, astrocytes can promote cell death or neuroprotection, depending on the situation. And GFAP is a intermediate filament that is present in these astrocytes. So as those cells turn over and die and form scars, this intermediate filament can become released in similar ways into the bloodstream. Intermediate filaments and protein biomarkers in general are a growing field, but very important in multiple sclerosis and other neurological diseases. Neurofilament is one serum biomarker, one intermediate filament that's well known, especially because of the work here in Ottawa. It's a neuroaxonal structural protein. And so when there's an inflammatory attack and neurons break, essentially, neurofilament is released into the CSF, and then a portion of it goes into the bloodstream, and we can measure that. So with inflammatory attacks or with age or with nonspecific head injuries, neurofilament can increase. GFAP is also this structural protein. As I mentioned, it's inside of astrocytes. So it marks things like scar volume and astrocyte turnover. And what they found is that both GFAP and neurofilament are higher in people with progressive MS. However, neurofilament increases with age, and progressive MS increases with age as well. So when neurofilament and GFAP levels are adjusted for age, it turns out that GFAP, but not neurofilament, is associated higher in progressive MS. So perhaps this protein biomarker has a specific utility in progression. In terms of MRI severity, both neurofilament and GFAP have been correlated with higher white matter lesion load, and inversely with white matter, gray matter, and cortical gray matter volumes. So as the brain atrophies more, these protein biomarkers actually increase. And so the important thing here is that perhaps these proteins that can be measured from the blood may be worthwhile outcomes to measure in treatment trials for progressive MS. Another important outcome measure in progressive MS is novel imaging metrics. So as I showed in the previous schematic, as the initial attacks occur and you have these contrast-enhancing lesions when all that inflammation and scar forms, along the edge, there's an iron-rich rim around these contrast-enhancing lesions, which are essentially caused by astrocytes and mostly microglia. So if you look at this picture here, you can see a T2 flare lesion, and on a T2 star sequence, around that lesion, there's this dark paramagnetic rim. And in certain cases, these lesions can slowly expand. Sometimes it takes over 7 years for lesions to expand, and that feature of an expanding lesion is associated with progression. Now, the problem is we don't always have 7 years to very carefully follow MRIs on patients. And by 7 years, perhaps the damage is already starting to be done. So another way to look at how microglia are activated is with PET. PET scans, positron emission tomography, is a type of imaging modality which can radiolabel different ligands. And depending on which ligand you radiolabel, you can see activity of different cell types. And one cell type that can be identified is microglia. And what they have found is that patients with multiple sclerosis compared to patients without multiple sclerosis have a much higher microglial activity. And this is important still because microglial activity can be abnormal in areas on the MRI scan that look normal. So this includes things like the cortical gray matter, which is hard to measure and really visualize on MRI scan. But on PET, we can see that microglial activity is increased in multiple sclerosis, and more so perhaps in progressive multiple sclerosis in the cortical gray matter compared to people without multiple sclerosis. So perhaps microglial activity on PET is another outcome measure that could be useful to track and to look at for trials in progressive MS. In fact, one of the studies that I was involved with during my fellowship was looking at that modality specifically, where they looked at ofatumumab, which again is that B-cell depleting treatment in patients. In this case, they looked at relapsing forms of MS. But what they did was they did a PET scan on these patients prior to starting treatment, and then at 1 week, 1 month, and 3 months after giving them this B-cell depleting therapy. And they used a measure of basically the lesional and perilesional normal appearing white matter, as well as they looked at cortical gray matter and the thalamic regions to see how microglial activity was changing after this treatment was given. And what they found was that after this medicine was given, the cortical gray matter significantly decreased compared to baseline. So perhaps there is some utility or some promise in PET as a treatment outcome for multiple sclerosis, and perhaps even PET as a diagnostic tool for identifying patients at risk for progression. Excuse me. So a few concepts in these progressive studies that I want to highlight, and one is that certain treatments ought to target the CNS component, especially the microglia, which may have an inflammatory activity in normal appearing brain. Many treatments for multiple sclerosis have targeted the peripheral immune system, but the CNS component might be active, as we're seeing in these microglial studies. Secondly, in addition to depleting one's immune system, neuroprotection is a feature that may be worth targeting in progressive studies to try to prevent brain atrophy. And thirdly, different outcome measures likely need to be looked at, and they probably have to be composite, since clearly counting relapses and counting new lesion formation is not appropriate outcome measures to look at in progressive MS, at least not as the only outcome. And these composite measures could include things like the EDSS, which does still have a very powerful prediction of people with progression, but also looking at functional scales, patient-reported outcome scales, and maybe novel techniques such as protein biomarkers or imaging techniques such as brain atrophy, lesion expansion, or possibly PET. One type of novel treatment, novel mechanism that I want to talk about are Bruton tyrosine kinase inhibitors, BTK. So BTK is a critical enzyme that's involved in B-cell maturation as well as in macrophage activity. And so blocking this enzyme may lead to basically preventing cell survival, aka causing cell death, as well as reducing the inflammatory cytokines that can be produced by these types of cells. BTK inhibitors are also interesting because they're oral pills. They can cross the blood-brain barrier, and as I mentioned, they can exert their effect on both B cells, but also on microglia. One phase 2 study looking at BTK inhibitors that was presented at ECTRIMS, one of the MS conferences back in 2021, was looking at which dose basically of evobrutinib was most effective. And as an outcome, they looked at the slowly expanding lesions and the volume of that. And they found that higher doses of this medication did decrease the volume of these slowly expanding lesions. And on a stratified analysis, perhaps even more interesting, was that they found that this medication, this BTK inhibitor, had more of an effect in patients with more advanced disease, patients with higher EDSS levels, patients who've had a disease course of over 8.5 years. The type of patients that tend to be progressive are the ones who had the greatest effect size for decreasing the slowly expanding lesion volume. And so this is quite important because essentially, historically, both treatments have been less effective in progressive patients, and the outcomes that we use to judge whether a treatment was effective or not have been less pronounced in progressive MS. So perhaps looking at these different outcome measures and these more CNS-specific treatments can actually demonstrate an effect in this population. Exciting about this is that there's many different BTK inhibitors that are being tested, and there's 3 studies that are looking at progressive MS specifically. There's the Perseus study that's looking at primary progressive MS, where they're looking at this BTK inhibitor versus placebo. There's another study called Hercules that's looking at the same BTK inhibitor in non-relapsing secondary progressive MS against placebo. And then interestingly, there's a third study called Fentrepid that's looking at a different BTK inhibitor called fenebrutinib, and they're comparing it against ocrelizumab. And so it's not a placebo-controlled study. Patients get a treatment either way. So that's quite an interesting angle to look at for this type of study. And what they're looking at is a composite outcome, looking at 12-week confirmed disability progression. So again, this 3-month disability progression. But they're looking at it as a composite score, EDSS, as well as the time 25-foot walk, the 9-hole peg test, etc., and hopes to find an effect of BTK inhibitors to help people with progressive MS. Another drug that I want to briefly touch on is this novel mechanism called RIPK1. The antagonist is called SAR44 for short, and basically RIPK1 is a critical protein in the TNF signaling cascade. So as you can see from this diagram, when TNF alpha interacts with the TNF receptor, it invokes a signaling cascade involving RIPK1, where eventually RIPK1 will dimerize and activate different ways of cell apoptosis or cell necroptosis. So SAR44 is a selective, orally bioavailable CNS penetrant inhibitor of RIPK1, which may actually be able to block this cascade and lead to reduced cell death and reduced neurodegeneration. The nice thing about this study that we're running in Ottawa is that it's going to be studied as a phase 2 add-on in stable patients with any phenotype of MS, relapsing, progressive, what have you, and patients are allowed to stay on their immune treatment and get RIPK1 as a potentially a neuroprotective add-on for a 2-year course. And the main outcome that they're looking at in this study is a change in neurofilament levels at the 96-week mark. So this is an interesting outcome to look at because neurofilament is correlated with brain atrophy and with neurodegeneration, of course. And RIPK1 is also being studied in other neurodegenerative diseases like ALS, for example. So this could be a different outcome measure in the phase 2 study to show a proof of concept that perhaps neuroprotection can be monitored in some way and then potentially helpful down the road. So I also wanted to touch on the importance of detecting progression early. Early treatment has been shown to improve outcomes in multiple sclerosis. And I presented this data previously, so I won't go into full details, but essentially during my fellowship, we were able to develop a predictive model that uses easily available data that's measured typically in an MS clinical visit to identify patients within the first 3 years of their symptom onset who's at higher risk for progression and progressive disease 10 years down the road. The AUC of this model was close to 77%. So it's not perfect, but at least it can potentially identify people who are at risk early and maybe give them treatment or at least monitor them closely if they're at higher risk. We were able to apply for a TAHEMO grant, which was provisionally awarded to investigate this notion further here in Ottawa. And what we're going to do first is validate this model that was developed using the Ottawa MS Clinic to make sure that the Boston population is not significantly different than the population here. And then secondly is to develop a web app, essentially, where clinicians will be able to input the specific data of their patient into the web app and output a patient-specific risk estimate for their chance for progression in 10 years. And if this proves to be useful, if the information proves to be useful for patients and providers, then our hope is that we may be able to find, treat, and recruit patients for progressive MS trials early before the neurodegenerative cascade has started. And then perhaps we'll be closer, identify people who are closer than others at development of progressive MS. Another study that we're looking at is the use of wearable technology to monitor MS function. So through basically this very important and successful collaboration between Dr. Ryan Graham's Gait Lab at the University of Ottawa and Bruce Ford and his team who formed the Celestra Health Systems, we were able to develop specific algorithms that can extract data captured by smart insoles to identify and track gait patterns. So the Celestra solution is basically using these smart insoles that have multiple pressure sensors, accelerometers, and gyroscopes within the insole and connected to a mobile app as well as a clinician portal. And the neat thing about and the important features of using smart insoles is that firstly, from the gyroscope and the pressure sensors, different gait algorithms can be created to segment the phases of gait. So heel strike, lift off, for example, and identify differences in the gait pattern. So for this patient, this is data from a real patient, the right foot has this normal appearing gait pattern, while in this case, the left leg had a circumduction gait pattern. And you can see from the gyroscope graph, there's a clear difference in how the foot is moving based on that. And so we can objectively identify certain gait phenotypes using smart insoles. Another important element about using smart insoles and wearable technologies is that patients with multiple sclerosis and other conditions may have more symptoms or more complaints later on in their walking, when they go for walks later on during their walk. So in the clinic, we may watch a patient walk up and down the hallway and push on their legs when they're having a neurological examination. But smart insoles can be used in non-clinical free living conditions when the patient's out at the grocery store or out walking around outside. And essentially, people can potentially have a normal appearing gait initially, and then at the end of their walk, the smart insole data will be able to capture how fast and how early the gait is changing, how fast the foot drop is starting, how fast leg weakness is starting. And this can be important because patients with progressive MS may not have changes in their EDSS when we see them, but earlier on, when they're out at the end of their walks, they can already start to have changes that we won't pick up on clinical visits. So what we were able to do is apply for the Ontario Centre of Innovation to fund a multi-center trial to basically provide these smart insoles and the patient-facing app to 90 people with multiple sclerosis. 30 at the Ottawa Hospital, 30 at Boston, and 30 in Barts Health in the United Kingdom. And essentially, we're hoping to assess gait data over 6 months in people with multiple sclerosis. and we're going to correlate the data that we capture from these smart insoles with their EDSS, the 6-minute walk test, quality of life questionnaires, in order to determine if these smart insole measurements in these free living conditions are more sensitive to changes and could be useful as both clinical monitoring for people with MS and also for treatment trials to see if their medications for progressive MS are actually working. Or even if with rehab or other medications, functional recovery can be actually measured in something like gait metrics. So there's certainly a lot going on in the area of treatment and progressive MS in general, how it happens, how to track it, and I probably could have gone